Hello, I'm Dr. Obey, and this is A Moment in Medicine. Our focus is health, education, and wellness. Our goal is for each and every one of us to have that opportunity to grow old. To grow old in good health. Welcome to our show. Well, we're here one more time, and I would like to emphasize sharing and caring because we care about each other, we share our med moments, and we come together and everybody will do better from a healthcare perspective. So let's talk about med moments for a minute. I haven't talked about this in a while. What is a med moment? A med moment is that instant or that time or that moment that tells you, oh, I should go see my doctor. That moment that you had that chest pain when you were walking up the stairs, or when you were walking down outside, your knees were hurting and all that arthritis is just bothering me so. Or the fact that you wake up with a headache sometime in the morning and maybe you get a nosebleed every once in a while and your blood pressure may be up. Those are med moments. That's when your body is actually telling you you should take better care of yourself. You should check with your doctor. Those are med moments. So don't ignore them because they're there and we all have them. So let's take care of ourselves. Let's go see our doctors when we have those med moments. Okay, guys, let's talk about this particular topic because it's Heart Month. I just wanted to talk about cholesterol and controlling our cholesterol and understanding that there is good cholesterol and bad cholesterol. You got the HDL, which is good, and the LDL, which is bad, and understanding that there are certain things that we can do to keep the cholesterol down so that we can be heart healthy. And it's Heart Healthy Month. So what can we do? We can limit the saturated fats. Okay, that's, there are certain, and these are fats that are in red meat, dairy products, and things like that. So if we limit those, we have a chance of decreasing our cholesterol. We can eat more fish, things like and salmon with omega-3s, very, very important for health. Okay, we can use more peanut oil and olive oils. These oils are better for us as opposed to some of the other oils that we cook with. And we can eat more oats and grains, all right, and especially nuts. Nuts are very good. Snack on nuts, excellent snack, and it decreases your cholesterol. Okay, we can also make some lifestyle changes as well. Think about exercise, a little more exercise, burning up a few more calories, losing a little weight. That's all heart healthy, okay? As they say, shrink that waistline a little bit, and it definitely helps, okay? And the number one thing that we can do as far as our heart is concerned is stop smoking cigarettes, the number one. If we can quit smoking, believe me, it does so much to strengthen your heart over time. Boy, you just do so much for your medical care, just your whole body will function better if you can get rid of the cigarettes. All right, guys. We're going to talk about a topic tonight, and of course it's my favorite topic because I'm a pulmonologist. We're talking about the lung. And I have somebody here, a physician here, that's going to cover it from A to Z. And he's Dr. Terry Anand. He is Director of Pulmonary at Newark Beth Israel Medical Center. Dr. Anand, welcome to our show.
Thank you, Omar.
All righty, definitely. I'm so happy that you could take the time out and come over and talk about the lung so we could just sit down like we were in doctor's lounge and just talk about it. You know how it is. But yeah, I think it's such an important topic because there's so many things out there that can affect our lungs, number one. And number two, if we can't bring the oxygen into our bloodstream, then we really have a problem. And there's so many of I know my patients and your patients that because of what had happened to their lungs, they're on oxygen and they're oxygen dependent, as we call them. So if we can prevent just one patient from becoming such a dependent person on oxygen, it's worth it. It's worth it. This show would have made its mark. So what I'd like to do, I'd like to just step back and just ask, what are some of the functions of the lung? How is it made up? Just tell me a little bit about the lung, and so that people out there can understand, get a better understanding on how the lung functions and where we are as far as physicians taking care of them with lung disease.
That's perfect. You have to look from two aspects: anatomical, the structure, how the lung is, or the airways and the lungs are. And the other part is the functional, what does the lung function as? So if you look structurally, you talk about air, how does air get through, either through our nose or through our mouth, into the trachea, and into these airways. It sort of branches out into smaller airways. That is about 22 generations of divisions that sort of goes through till it reaches what's finally called the respiratory bronchioles, or the alveoli, or the lung sac, where the actual function of the lung takes place. Now, why is lung important to us? Well, primarily to get oxygen. We need to get oxygen to our blood, so the oxygen is utilized for a variety of different functions, for the cellular functions, for the metabolic part of it. But you also, at the same token, your body produces carbon dioxide on the other side, right? The cells, the tissues. That's the waste product that we need to get rid of. So that is also helped by the lungs. Well, how does the lung function? Well, we normally take a breath and the muscles contract. In this case, the most important muscle is really the diaphragm for a healthy person. I'm sorry.
No. I was going to say the diaphragm. I was going to say where it was. It's that muscle that's at the base.
Correct.
What you're talking about. And actually, when we take a deep breath in, it actually pushes down.
Towards the stomach, and the lungs. It creates a negative pressure. The lungs open up.
Negative pressure. Yeah. Tell me about this. The thing of it is, it always amazed me that when we exhale, or when we let the lung is like a balloon. I've always thought of it like a balloon. And so when a balloon, when you open the spout of a balloon, the balloon collapses down. So why don't our lungs just collapse down to nothing like a balloon does?
Well, it's very
that negative pressure, that thing that you said.
Exactly what you're saying, because there's pressure from the atmosphere outside. And there's the negative pressure we create. In this case, the diaphragm pushing down. The lungs open up. When we exhale, it's usually passive. Passive means a muscle. There's no real muscles that involve contracting, forcing air out, unless if you have a diseased state. For normal people, the elastic portion of the lungs, the diaphragm, the chest wall, all sort of come back, collapse itself, but not completely. It doesn't totally collapse, because part of it is the balance between the outside atmosphere and the negative pressure that we have in our chest. Balance it out. There's some amount of lungs will be open all the time.
All right. Now, you talked about, there are two words, oxygenation and ventilation.
Correct.
All right. And oxygenation, just really explain oxygenation. What are you talking about? You're talking about breathing air in, and something happened to the oxygen to get it into the bloodstream. How does that actually happen?
Well, it's oxygenation is essentially, as you take your breath in, percentage of the air that we breathe in, 21%, roughly, is what the oxygen concentration is. That part is brought down into the lung sac, the alveoli, where the blood supply comes across. And now you have a gas exchange from a higher concentrate of oxygen to blood that's being brought back from the body with low concentration of oxygen. So you have this driving force, a gradient, from a higher concentration to lower concentration. So gas, in this case oxygen, diffuses across the membrane into the lung sac, into the blood vessels, and that supplies the body. Now, as you that's the oxygenation part. Now, if you really want to look at it, you can paralyze somebody, just give them oxygen. You can oxygenate them. What you can't do is can't get rid of the carbon dioxide.
Okay.
This is where the respiratory system has to be functional. When the carbon dioxide do come up, when you exhale, the carbon dioxide is exhaled out.
Right.
And then there's lower carbon dioxide there for the next cycle
to come through. You know what I always think about it like a car.
Yeah.
And if I think about it like a car, then it makes sense to me.
Yeah.
You know, a car uses oxygen and gas, and it produces carbon monoxide.
Yeah.
And we use oxygen in our calories. And calories, we burn calories. Instead of gas, we burn calories. And we produce carbon dioxide. Yeah. Well, when the carbon dioxide comes up into the lung area, it's pushed out.
Correct.
It's pushed out. And I always think about it that way, but that way it kind of stays straight in my head. Yeah. Interesting. Very interesting point. What are some of the tests that we use as a physician to truly evaluate the lungs? So say if someone comes into your office and they have asthma or they have bronchitis, or what tests are you going to send them for to evaluate what's wrong so you can give them an answer what may be the cause of their shortness of breath?
I think there's two ways to look at it. You can look for structural abnormalities, which in imaging studies would be useful in this case. Most common would be chest x-ray. And something that's not quite clear with a chest x-ray, or you still suspect something structurally going on. A CAT scan would be more sensitive to note those diseases or defects, you know, whether it's tumor in your lung, whether it's pneumonia, you know, whether you have pulmonary fibrosis or lung scarring.
Right.
On the other side, you have the functional testing that we can do. That is, how well does your lung function?
Right.
So the one that we typically use is what's called pulmonary function test.
Okay.
And the most common of that test is really the spirometry. This is where, you know, you have a little mouthpiece, you take a deep breath in and blow hard and fast as you can till you completely exhale the volume that you could. And then the computer calculates in the first 1 second how much lung volume did you exhale, and then as compared to the total. You can calculate various different things. The numbers are based on reference numbers, and the reference numbers varies for a person because of their age, their sex, their race, and their height. These are four more important predictors. So somebody, you know, it's me, 5'10", you know, Asian, you know, male. So there's certain numbers that would meet within that criteria that it should fall in. If I'm outside that norm, especially when it's low, it's considered abnormal.
Okay.
And one of the things that the amount of, in this case, if you think about asthma or COPD, which is, you know, very common in this country, the amount of air that you exhale in the first 1 second, typically 80% of the volume you should exhale out. But it would generally consist something of significance less than 70% of the total volume. That's one way to do is a test. Those patients are particularly smokers. This patient exposed to noxious fumes, things that can affect the lung. Try to catch them early.
Yeah. Alrighty, and that part of the test. So when you're talking about pulmonary function test, if you're talking about exhaling, maximum exhale, and how the volume that you can exhale in that 1 second, you're talking about the airways or how open the airways are. You're actually evaluating the airways doing that, right?
Correct.
You're not evaluating the tissues itself.
No.
That's why I always think about lungs. I always think about that. Tissues and tubes. So I want to evaluate the tubes for like spasm and asthma. But then again, I want to evaluate the tissues of how easily can my tissues expand to take in a volume?
Yeah.
Tell me about that part of the lung test, that we usually call a total lung capacity.
Yes, yeah. Well, typically, there's the first part is this spirometry. It's very easy to do. It's widely available throughout the world.
Right.
Certainly, we have capabilities of measuring the lung volumes.
Right.
You know, and there's two different methods to do it. One is the body box.
Right.
You know, you put in a telephone type of device, telephone booth, I would say,
Right.
type of device. You sit there, and you know you can change the pressure and the volume. What happens in the booth compared to what happens on the outside, and they're able to calculate these lung volumes.
Yeah, the differences.
You know, and then the other way is using a inert gas that they can use to measure your lung volumes. Those are very important. Kind of tells you a few things. One, what's the total lung volume? Sometimes it's artificially low on a spirometry, but it might be normal on this. And the other thing is sometimes you truly have loss of some of the lung volumes, which
Right.
can indicate certain diseases,
Yep.
you know, such as pulmonary fibrosis I mentioned earlier. You know.
Yeah. Excellent, excellent, excellent. There are other procedures that we do as doctors, and especially lung specialists. One that many of the people out there that are looking at the show may either a family member may have had or they may have had, called the bronchoscopy.
Yeah.
Oh, that fancy word, bronchoscopy. Could you tell us about that? You know what I mean?
I think
a little bit, and why we would do it.
Yeah.
For something.
I think people are more familiar with the gastroenterologists when
Yeah.
they do gastroscopy or colonoscopy. Colonoscopy, I think, what most people are very familiar with. You know,
Right.
they see it over and over on television. Bronchoscopy is done much less, you know, because the selection of people you do it, it's very small compared to the routine screening on
Right.
some of the other patients. It's a similar. The technology is very. It's the same technology. You have a long tube with a lens and attached to a camera, and the tube it's smaller than do a gastroscopy, colonoscopy, thinner, and essentially, you know, you do this on patients to evaluate if there's something going on. Particularly, we're looking for tumors or sometimes infectious cause. You know, or if there's an airway issue that it's narrowed, or there's something going on there. The patient, it could be done as an outpatient for some people. They come in, they're given a little bit of sedation, so they don't quite recollect the procedure.
Right.
You can either go through the nose or the mouth, depending on the operator's preference, and you can look and evaluate the airways. You can collect specimens and send it out for a variety of different analysis. You know.
Now, with this procedure, and I know it's a tube that has sort of a handle on one side, so you can kind of direct the
Yes.
scope where you want. It has a camera on it, so you can see exactly where you're going and looking
Yeah.
at the airways as you go down. So can you take biopsies, and can you suck back the mucus and send it to the lab? That's how you do it?
Yeah, exactly. I mean, you would, well, the simple thing of the BAL, which is the bronchial alveolar lavage, you would instill saline, typically.
Like salt water.
Salt water. And then you would just push it in and aspirate back and have the cells in the specimen looked at for cultures and look under a microscope. You can also, if you see any abnormality or if you see tumors, we can take biopsies, a tiny forceps, long wire with a tiny forceps you can pull out. The technology, you know, as you understand, it's evolved. Now we have different technology surrounding it. Now we got more and more sophisticated, going into almost like a GPS
Yeah.
type of
It's
scenario.
like a mapping.
Like a mapping,
You know, you follow the GPS till you get to the
Yeah.
point where you want to be.
It's gotten very
pretty cool.
sophisticated compared
Yeah.
to when we first started.
Yeah, it's pretty cool what we can do now with this. And also, you know, I just recently had a patient that will be doing some stuff that may have a foreign body, and foreign body meaning that something that shouldn't be there in his airway, and they'll have to actually go and pull it out with one of these procedures. So it's pretty fancy stuff that we can do.
Yeah, it's got a therapeutic implication. You know, we always think about diagnostic, but there are therapeutic implications like foreign bodies. And you know, a lot of times it's kids, but occasionally adults accidentally, aspirate. these objects into the airways, and they can't effectively cough it up. So you really need to go in there and take it out.
Take it out, yeah. And over time, it can cause infections and stuff like that, so you have to get it out.
Yeah.
A foreign body in your airway is not a good thing to be.
No, you get it obstructed. You get infected beyond the obstruction.
There's something that it's called a thoracentesis.
Yeah.
And it's a big word. If you could break it down for us and tell us what's going on. But we do this every once in a while too, as with the lung. Tell me about this particular procedure.
Well, typically, outside the lung, there's a membrane called pleura. One that just coats over the lung, and another one that coats on top of this. Normally, a very thin layer of fluid is there. That's normal.
Right.
But sometimes, because of disease process, for a variety of different reasons, you can have collection of fluid there.
Right.
And sometimes very important, whether you have a tumor, whether you have an infection, or due to something else, you need to find out why do you have it, or even the fact that if it's large enough, it might cause you to be short of breath. That you're not able to get enough oxygen. So what typically we do is, there's a couple of different ways. If it's large enough, you might not need imaging. But if it's, these current days with the ultrasound, which is readily available, we typically would evaluate where the fluid is and try to get a sample there. The procedure involves giving a lidocaine or some sort of local anesthetic, like what the dentists inject into your gum before they work. We do the same thing on the skin and the tissue and of the chest.
Right, so numb up that area.
Numb up that area.
Right.
And we insert a tiny, it's a long needle with a catheter on top of it. We would go inside into this space and put the catheter in. And once the catheter in, we would drain out the fluid there. Now, like I said, it could be for therapeutic. Sometimes patients collect these things that need to be drained and give them symptomatic relief. For others, we actually need it for a diagnostic purpose, whether there's a cancer involvement there, whether it's an infection that's involved there, or just a diagnostic to say that it's not.
Right, to say that, right. Yeah. So let's think about this for a second. What we're talking about is that between the lung and the chest wall, there's a little bit of a space.
Yeah.
And there, in that space, there's a little fluid.
Yeah.
Over time, sometimes, for whatever reason, and it can be for many reasons, the fluid does not drain out appropriately or overproduce, and the lung actually is pushed up, and the fluid, so there's a big area of fluid there that the lung used to be in.
Yeah.
So we actually have to go in and actually take that fluid and drain that fluid out so that the lung can come down and be re-expanding again.
Correct.
And that's what we're talking about, and that's a thoracentesis.
Correct.
Interesting. All righty. Let's talk about this. As far as smokers.
Yeah.
And along the airways, I've always remembered my professors used to say that there are cilia along the airways. All right. And these cilia are so important as far as the function of the lung and keeping our airways clean and the mucus flowing. Tell me about that. What happens to these cilia when you smoke, and what happens to the lung because the cilia are maybe not working very well after cigarettes?
Well, you're exactly right. I mean, these cilia actually help clear the airways for us. They usually propel these stuff forward into your mouth, and you sort of swallow, what you're getting there. Now, whatever we breathe, there's a lot of dust, bacteria, and other things. There's a first defense. Certainly, the nose would be the first one, and then the airways in your lungs are the second. The function of the cilia, just like I said, pushes forward, but smoking causes damage to the mucosa that prevents these from doing their job.
Yeah, so the mucosa is actually the skin is what you're talking about, right?
Yeah.
And the cilia kind of popped up on the skin.
It's an air-like structure that, if you look under a microscope, you'll see it as such. And that function is impaired.
Right.
And smoking has a variety of other things cause inflammation of the airway, mucus production. All these things becomes very much impaired. The risk of you developing further damage of the airways, is increased.
Right.
What you're doing there.
I understand. All righty. You know, the thing of it is that you had talked about the first line of defense for our lungs and the second line of defense. The nose and the air and then the upper airway is the first line. You said that's the first line of defense?
Yeah. Well, most people, we breathe through our nose. And the nose is very important. I guess people, apart from smelling or eating and so forth, air and dust, you have a couple of things happen. The nose had a lot of little ridges. It's very, one of the primary thing, what it does is whatever air, whatever you're breathing in, it would moisten it. Otherwise, you're breathing dry air. You know? That's first important. The second thing, anything that's in there like smoke, dust, all these things sort of get caught up here first. That it sort of filters a lot of stuff, makes the air a little more pure. I won't say it's totally pure, but a little more. And that function is very important, in breathing. What we do,
Right. Well, we're gonna wrap it up right now because we're coming to the end. I just want to say that the lung is such a dynamic organ, and it's one of the things that I have noticed over the years is that the ability for patients to actually take care of their lungs and do better with their breathing. I think overall, I may be an optimist, but overall, I think it's improving. I think that people are really trying to take care of themselves more, and they're recognizing what they can do to make their lungs a little bit more healthy. Like, for instance, if you're jogging and if you're using your lungs, then basically that's going to improve, your abilities to breathe, your ability to oxygenate, your abilities just to be healthier all over. I think the overall realm of becoming healthy, being healthy, trying to hang in there with health is on a rise, and that's a good thing. And the lungs are playing a major part of it, and I'm just so happy because I'm a pulmonologist. But the thing of it is thank you for coming in.
It's a pleasure.
It seems like the time always goes so fast. We just it sort of hit the tip of the iceberg, and there was so much more we could have covered. Hopefully, we'll be able to cover it at another time. Dr. Anand, thank you for coming in and covering the lung for us. All right. In closing, sharing and caring, all right? We definitely want to care about each other, and that means sharing. And I will keep preaching this because if we all come together and share our med moments, we can be better healthcare consumers. Never institute any change in your medical care until you consult your physician. I trust each and every one of you continued good health. I'm Dr. Obey, and this is A Moment in Medicine. Until next time, peace to you all. All right. It'll just play out.